Hi, we're now going to talk briefly about MSK ultrasound of the lower extremity. Just like before, you'll need an ultrasound machine, a linear probe, preferably, since it's a high-frequency probe. If not, a curvilinear probe is acceptable. We're going to jump straight into the knee. Alright, so first and foremost, there's a few different reasons you do knee ultrasound. You can do it to look at the major tendons, namely the quadriceps tendon there and the patellar tendon there. You can do it to look and see whether there is a knee effusion, and occasionally you can do it for fancier things as well, which is outside of the scope of today's discussion. So we're going to start with a little bit of anatomy appropriation. So to do this ultrasound, you're going to have your patient with their leg propped up on a bunch of pillows. You're going to start with a short axis view of the quadriceps tendon. You're going to be superior to the patella, and you're going to be looking to see right there you're going to be looking right here to see the two femoral condyles. You can see articular cartilage there, and this quadriceps tendon right there. And you'll be able to see that it's this large structure that as soon as you start moving superiorly, will start to lose that epigenicity and become muscle. Okay. From there, you can rotate the probe 90 degrees so that the probe marker is pointed up, and you're going to be looking to see that you can find right there the head of the femur itself. You're looking right there to see the quadriceps tendon as well, and then you can see a little fat pad right there. Now, the quadriceps tendon, when you see it in long axis, as a reminder, you can expect anisotropy to make another appearance. So anytime you're looking at a tendon in long axis, you should see it to be rather hypercoic. If you don't, make sure you're perpendicular to the tendon, because if you aren't careful, you can have this experience where you can see that bright white hypercoic area become rather dark as you rock and tilt that angle on and off. The next thing you're going to do is you're going to move the probe inferiorly and down underneath the patella itself, tracking the patellar ligament inferiorly and looking to find where that tracks. So there you see patellar ligament right there, nice and hypercoic, and you can see it running right over the tibia itself. You would do the same thing in long axis, and you would again visualize patellar ligament there, fat pad there, and then there is the tibia. And you can see that bright hypercoic patellar ligament running right through there. One of the abnormalities you can see is a effusion. So here you see skin, subcutaneous tissue, right there is femur, right there is tibia, and then you see this large amount of anechoic fluid, and that's what a knee effusion looks like. Another brief reminder from the upper extremity lecture, we'll talk again briefly about what a nerve looks like. The epineurium is usually that bright white line surrounding the entire nerve. You'll see that the fascicles are these bundle of grapes hypocoic area with a hypercoic line around it, that is the perineurium. If you look in long axis, it looks similar to a tendon. The distinction is obviously 1 in short axis, they look different. 2, as you track superiorly, a nerve will continue forever, or until the nerve ends, but a tendon should end rather quickly. So the next step is to look at the popliteal sciatic nerve. Very useful nerve to know the anatomy of. It runs in the popliteal fossa right here, and then it actually splits from the tibial and the peroneal nerves. And it is a nerve block of a lot of usage, especially for nasty lacerations of the sole of the foot, pain control for medial-sided fractures on the ankle, etc. So tracking the separation and conjunction of the tibial and peroneal nerves is very helpful. So here you can see that that is tibial nerve right there, that was peroneal nerve right there. And as they're sliding the probe superiorly, they come together. There they go, there they go. As a brief reminder of general anatomy, you'll usually find this in the popliteal fossa. The popliteal fossa is where you'll also see the popliteal artery, along with the popliteal veins that trifurcate. The popliteal vein trifurcates, pardon me. And that popliteal vein will help you figure out where you are. Now bear in mind that both of those will lie just proximal to the tibia itself, and then the nerve usually lies proximal to those, or superficial to those for a better descriptor. And this is a nerve that's very helpful to find in case you need to end up blocking it for the lower extremity. Okay, and then finally let's move on briefly to the ankle. Now in the ankle, what you're looking for here is you're looking to see if there's an ankle effusion. Your probe marker is pointed towards the head in the long axis at the conjunction of the tibia and the talus. You're seeing here, this is the tibia, That's the talus. That's a vessel up there. That's various muscles, tendons, etc. And now, if you rotated 90 degrees to short axis, you could look through that again, and you would be able to sweep through and examine the tibiotalar junction and look to see if there's an effusion there. There, as you can tell, you can see the posterior tibial artery surrounded by veins. This particular example of someone is rather well hydrated. And then this is an example of a large ankle effusion. So right there is tibia, right there is talus, and then this anechoic fluid structure right there is a large volume effusion for the ankle. Now when I say a large volume effusion for the ankle, most ankle effusions are usually a couple of cc's. This was about 15 cc's of purulence and ended up being a septic joint. Okay, so this was a very brief run through of how you would look at each of these joints. You'll get to practice this in real time on standardized patients shortly. And if you have questions, again, my email is sodi@rowan.edu. Feel free to send questions my way. Thanks, bye-bye.